Aortic rupture during TAVR, a rare but known complication. After more than 20 years since the invention of TAVR, rupture of the aortic annulus is still a catastrophic but rare complication, occurring in less than 1% of cases, with a risk of death up to 48.4% in contained and 75% in uncontained ruptures. Advances in smaller profile transcatheter valves, better pre-procedural patient selection by using imaging modalities that allow assessment of calcification and correct valve sizing can help in the prevention of this complication. In the event this unfortunate complication occurs, a well-prepared cardiac team to respond is key. The patient is an 83-year-old male with history of N-STEMI status post PCI of the RCA, hypertension, hyperlipidemia, who presented with worsening dyspnea of NIHA class 3. Echocardiogram revealed severe aortic stenosis. The patient consented to elective transcatheter aortic valve implantation. 14 French E-sheath over an Amplas SS wire and 12 mm Armada balloon were used for a valve access. While trying to cross the aortic valve with a 26 mm Edward valve, the patient developed severe hypotension. TEE showed aortic root perforation by the non-coronary side. The patient was put on a VA ECMO while continuing CPR and underwent emergent thoracotomy. After the aortic root was surgically repaired, the 26 mm Edward valve was deployed again across the aortic valve. The patient survived without significant complications. Aortic rupture during TAVR encompasses injury to the aortic root and the left ventricular outflow tract. Aortic root rupture during TAVR is associated with several risk factors: oversizing of the valve more than 20%, pre or post balloon dilation, calcium in the LVOT, severely calcified bicuspid aortic valve, severe annular or subannular calcification, amongst others. There are 4 types of annular rupture, divided based on the anatomical region of the injury: supraannular, subannular, intraannular, and combined rupture. Rupture of the non-coronary sinus of Valsalva is most commonly caused by calcific deposits between the anterior mitral leaflet and the sinus. The most common immediate sign is rapid hemodynamic instability. Aortic rupture can be identified clinically by transesophageal echocardiography or angiography. There are several options for the management of aortic rupture: conservative management, pericardiocentesis, surgical repair, or valve-in-valve procedure to seal the rupture, depending on the site of rupture and the clinical symptoms. Aortic rupture is a rare complication of TAVR. Identifying the calcium burden pre-procedure, appropriate selection of the patient population, careful sizing of the valve, and avoiding aggressive balloon dilation pre and post-procedure can help minimize the risk of this devastating complication. Immediate management to combat hemodynamic instability and the appropriate management strategy based on the location of the injury and clinical signs should be applied.